Hello, everyone. Welcome to the Practice Perfect podcast. My name is Jennifer McNamara. I'm your host. I have my lovely co-host, Maya Turner, here. Welcome to the show, Maya.
Hello,
Hello,
everybody.
everybody.
Happy
So, Happy
Wednesday.
Wednesday. Happy Wednesday. So excited to be here to talk about one of our favorite topics today. But before we get started, I just wanted to let everybody know we are less than a month away from the virtual Bone and Joint Summit of 2025. We are so excited. So I want to
Yes.
remind everyone, get your tickets because it's going to be the event of the year for orthopedics. If you work in orthopedics or you're interested in working in orthopedics, it is going to be amazing. So we are very, very excited to have everyone here live today on a very important topic. Copy, paste, repeat. Copy, paste, repeat. The hidden risks of EMR documentation. Maya Turner, right here on the screen, has recently talked about this topic in a webinar. So I'm sure it's fresh in your mind. Maya, tell us, what does copy and paste mean in the world of documentation?
Okay,
Okay,
so everybody
so
knows
everybody knows.
how. Can you hear me? An echo? You hear an echo?
I'm good.
Okay, so copy paste is when a provider takes everything that's from one note and inserting it into another note without modification. And copy forward is taking one piece of information into another note. And Medicare considers cloning and copy paste one and the same. Um, there's certain rules and regulations that you have to use in order to do that. Um, there has to be appropriate attribution, meaning if you took it from one note to another note, you have to attribute who or where the note came from for it to be usable because you're adding your own content. It's almost like plagiarizing, right? Word for word, but in medical record documentation, it's called copy paste. So if you plagiarize in the college world, um, copy paste in the medical world is very synonymous and it's the very same concept.
Right. And I think looking back to when we started using EMRs, right, this became an issue because we had paper charts before then. And so everything was, transcribed by a transcriptionist, technically. And before then we had handwritten notes. I still remember my very first time I learned auditing was when I was working as a coder. And the auditor in our department, she was a nurse by trade. And we were just talking one day, and she asked if I wanted to learn how to audit E&Ms for neurology. And I was like, absolutely. Anything you want to show me, right? So I learned how to audit an E&M node. Blackbook was 95, 97 guidelines, from chicken scratch, right? Like, so they would just write it down. Like, you could barely read it. It was bad then in that way too, but that was different because now we can see it. It's all legible, right? We don't have to worry about what is being said. We can see it, but it's not always accurate. And so that's the issue we're facing, is that, and not all EMR systems are created equal. They're supposed to make things easier, but oftentimes they make it more complicated. They make it so much easier for us to commit fraud like this, and to make it easier for the accuracies to show through, where we're not reporting the truth of the encounter because of this capability.
And back in the day, they used to have a saying, if it's not documented, it didn't happen, right? But now in EMR, they're saying it's documented. Did you do it? So it's a very interesting turn of events on how EMR has made such a impact on the
Mhm.
integrity of documentation from the physician. If they're not trained and the EMR is subpar, you're going to more than likely have more problems than not. So it's going to be really interesting how all of this kind of plays out.
Right. And when the new guidelines came out in 2021, revised in 2023, we had the concept of, hey, providers overworked, they're overwhelmed with documentation requirements, burdens from administrative sides, obviously the payers requiring more extensive documentation, and they're just overwhelmed, right? So that was it's supposed to be a good thing. It was supposed to help them out. It was supposed to be good. But ultimately, what's causing the problem is all these different features, not understanding what they're supposed to click here and click there. And now we have tools on the scene to help them do that better with artificial intelligence, things that are going to help them streamline pulling data from different places more efficiently, supposedly. But even with those AI tools, we're seeing issues. Now, one of those issues that I have seen, and just I think we've other podcasters have talked about, like Sean Weiss and Terry Fletcher. So I wanted to like kind of just add to this as well. Reminders: if you have an EMR, like a bigger one that is using AI, some of the larger ones are using it. You might see at the bottom a disclaimer that mentions that artificial intelligence was used, or some kind of notation, but it doesn't replace the fact the physician has to attest to that documentation. So if they're using artificial intelligence, they're attesting that they've reviewed it and they agree with it. Disclaimer or no disclaimer, the responsibility lies with the provider, the physician of record who is seeing the patient face to face or providing the service. They are responsible for making sure that what they're signing, they feel is accurate. They agree with it.
It's very interesting that you're bringing this up. And I had several conversations in regards to AI and how it transcribes, the note. And actually on Facebook Live, AAPC, with
Mhm.
myself, and Dave, as well as Andy, with a couple of people, Ellen Hinkle and Rena Genovese. We're all going to be talking about AI and how it translates to the real world, and that'll be at 11 a.m. Mountain Time. So, but
Yay.
yeah, so it's interesting, and I had this conversation at HealthCon, and I'll just say this: AI is a tool to augment. It is not to automate. And when we
Right.
think about augmentation is to enhance the experience or the tools that the physician used to document the record. And there are some AI tools that are great, and there are some AI tools that are not so great. And I think part of the problem is that when these AI tools, when it comes to medical record documentation, don't have coders, or they don't have compliance entities helping to make it fluid when it comes to the process of coding and documentation and how it's captured. This is why the coder is and going to remain relevant. Because again, there are several things that could happen in the room that may not be captured on camera, right? And I think there's a lot of things that happen that may not be captured in words, but can be captured in the physical or the tangible aspect of the examination. So if the physician forgets to say it, there's just a whole lot of questionable um, existence when it comes to AI, and how automation versus augmentation, and the interpretation of how that is played out when it comes to AI and when it translates to the medical record. So I think that's really um, an important point to bring forward, in that AI is supposed to augment, enhance the physician documentation experience, and not automate.
I love that. Great way to say that. And we also know that AI is being used to abstract codes and in some cases suggest charges and even go as far as to build it out for you. So, hey, who needs builders and coders when I got a machine to do the whole thing for me? I can save tons of money. I'm going to be swimming in cash. My
And I'll just, girl, don't get me started. I'm on my soapbox. I'm on my soapbox. Girl, okay. If you've ever used ChatGPT and
oh,
and you've used it, right? Has it always been correct?
I would even go close. I would even get close to the word always at all. Like, is it ever correct? No, I'll give it its credit. There are things that it can pull out that are great and good information, but it fails so much of the time.
I'm just, man. And I think if we use and to be honest, let's just keep it real, right? it only, uh-oh, I'm about to say something, Jen. It only puts out what you put in. Uh-oh.
Yeah.
So, okay, so if you're putting this in, I'm just saying, soapbox moment. If you're putting this information into the system and it spits out what it thinks, how is this going to make a difference when you use AI?
And I'll be honest, I've talked to a lot of professionals. We know some professionals that are working in this field, and they're very educated and very great at what they do in that world. And there are other types of tools that are more advanced than ChatGPT, yes, and different versions of AI. I will give them that. But what we're seeing on that front is that you can't always trust where it's getting its information. And that is what my concern is. Because when we have issues where you have copy and paste, where the organizations or the EMR itself, like we just forget AI, for instance, let's just look at the EMR itself. If it is preventing physicians from getting accurate information into the system, then AI cannot pull information that is accurate for the billing process. So it's only going on the data you give it. So if you give it bad data, it's going to put out bad codes and bad processes, and you're going to not get accurate payment. You're going to get audited potentially, and you're going to have to send it back. So it really just never existed in the first place.
I'm so bursting at the seams right now. And I think that's part of the drawback when auditors don't have access to the real EMR and the entire, especially when you're dealing with EMR claims for hospitals, and you don't have access to the system. I'm gonna tell you why. When you're dealing with auditing, uh, EMR systems like Epic and ECW, which is probably one of the most popular, two of the most popular ones, Cerner, those types of things,
Mhm.
you can actually hit a feature and it'll tell you what's brought forward, what's revised, and that kind of thing.
Mhm.
But when you're dealing with a paper record, let's just keep it real. When you're dealing with a paper record, it's hard to tell what's being documented from the day before and the day after. So if you really want to be a true auditor and you're requesting records, you need to ask for the day before, the day after. You need to have two visits before and two
Mhm.
visits after, because that is the way that you're able to interpret what's being copy paste, especially when you're dealing with the world of evaluation and management. There are
Mhm.
times when you're looking at a cloned note or a procedure note that is a procedure note. You can tell that it's cloned or a copy paste or a template because it's not specific to the patient. Those things are maybe easier to pull out. But when you're dealing with things that are related to E&M, where it's based upon a day-to-day basis on a daily encounter of the evaluation and management experience, and you don't have access to the records 2 days before, 2 days after, or even the entire stay, it's going to be hard for you to tell what's brought forward, what's cloned, and what's not. And that's the risk that we take when it comes to that. So I just wanted to bring that to the forefront when it comes to templates, AI, copy paste, copy forward, and templates.
Yeah, recently I was training my coders on one of our clients, and we were looking at one of the notes in one of the bigger EMR systems, and it's like I hate it that it does this, but it makes it so hard when you're coding consults because it brings over all the dates for that stay into the same every note. So if you're not a trained coder and you don't know what you're looking for, you're looking at the HPI and the exam, but it's copied over from the previous visits, but you have to go by the date stamps because it pulls on each date. So like you have to find the date of what the provider documented. And you know what they're doing? They're giving you two sentences of what they did that day. And you're going to the bottom of the impression and plan. You're looking for all of the diagnoses, and there's like 10 of them, right? And you have to be able to find the diagnosis that they're making notes on because that's how the EMR works. The EMR allows them to notate under the diagnosis that there is relevant for them that day. So it's so frustrating because when we're auditing, when we're coding, it's hard for us because it's not clear and it's a lot of hunting down the correct information. It's not efficient. And I can bet you that if AI was used in this platform, I don't even want to know the headaches and the trauma from this billing that is happening if it's using this EMR system to pull out data for this. Like, I would just not want to even be near that because, oh my goodness, it's a mess.
Oh, Jennifer, my dear, dear friend. I've been teaching auditing and evaluation management for physicians for years, and I've been in compliance for years. And one thing that I have seen, and I think this is why CMS has changed their rules in the initial visit in the hospital, is that you can only get one initial visit per hospital stay. There's a reason why, because there are so many notes that are in the system that it's copy paste so bad, you don't even know who wrote what and from what day. It's that bad. And now I'm beginning to see why, and I could actually see why the EMR system that you use for that consult note brings everything forward. From an auditing perspective, I would love to see that. But from a coding perspective that's looking to abstract from the day of, again, you need to see what's brought forward. You need to see what they're managing, monitored, evaluated, assessed, and treated. I don't care if that's the term that's used for risk adjustment. It needs to be relevant for anything that's related to E&M. It's a terrible thing. Um, and I've seen things go all the way up to the Department of Justice where the physician had to defend themselves. I mean, it was a medically relevant visit, but if everything was copied forward and there was an adverse effect for that patient because they were um, a certain specialty, what can the physician be held accountable for if there's nothing to show what they managed, if it was copied forward from the previous day? And the answer is nothing. And if the DOJ can validate that the visit was medically necessary, but you can't validate what services were being managed that day, then you have a huge problem because you're not able to tell what's being managed on that day of service.
Yeah,
And it's a terrible, terrible thing. And we have to just be very careful. And I've been very successful in the training of the physicians, but is it going to cure the problem? Absolutely not, because there's always going to be a means to use something that was done before. It's just how it's attributed and how it's updated in order for it to make the difference.
right. And there's things you can do, right? I mean, you can train your staff. Let's talk about what we can do. We can't fix everything. We're only one person, right? When we're digging into this, we can only do so much, but we can be part of the solution, not the problem. So
Yeah.
let's think about what we can do in our organizations, train our staff on the danger of this. Now, hopefully you have a policy on this in your organization as part of your compliance program, because that's one of the things I always, when I help organizations manage their compliance, that's a policy we have to put in there. It's got to happen.
Yeah.
And then having it part of your compliance training. Now, you might use a third party, and we use third party training modules in some of our trainings for compliance. But we also have additional training that we put out on our training site for our employees and our consultants to have access to that work with us, so that they understand that as well, right? Making sure that just training is number one. They got to know that it exists and they got to know what to look for, and have it audited regularly. There are repeated phrases, unchanged exam findings, outdated timestamps, like things like that. I'm going to give you an example. And Maya knows this example. I was auditing for a third party. I'm helping them with some primary care stuff. And I was going through one of the notes, and it was one of the EMRs that she mentioned earlier that I was using. Unfortunately, of course, or when you go and you audit E&M, for instance, you're looking at various things, and so the lab's got to make sure they document, what labs they're reviewing or ordering, and the findings, right? So the findings were exactly the same, word for word, verbatim for every single lab test. Now, if you know anything about lab tests and what they're used for, like what are they checking for? The CP, the CMC, oh my goodness, the
The
CBC.
C the CBC, CMP, yes.
the acronyms, like my tongue is twisted today. And the one they check for, right? There's certain ones that check for certain functions in your body, right?
Yes.
So it would make sense that the findings would go along with that lab because what it's looking for. But what's exactly the same across the board, it makes no sense. And it's not an accurate legal document for the patient, ultimately. So if they got a hold of it, they would just be totally confused. If a lawyer got a hold of it in a case, they would be, I guess if they're the prosecutor, they'd be really excited.
Oh, girl. Oh, don't get me started. Don't get me
Yeah, I'm
started.
like, oh, good one, guys. We gonna win.
Man.
Yeah,
Oh, okay. I had to tell you, I mean, and many of everybody out there knows that I'm an expert witness, and I've been on cases in this regard. And one of the cases,
she laughs.
oh, oh, girl, it was so bad. It was a copy paste note. I can't say what kind of specialty it is. I can't disclose a whole lot, but one of the rules that are associated with any type of modifier when there's an assistant surgeon, a co-surgeon, or what have you, um, you have to say what the other surgeon did specifically,
Yeah.
right? You have to say that. That's part of the note. If you have a co-surgeon there, you have to list their name and you have to say what they did. The appropriate modifier, whether a co or assistant, or even a second, is it a second assistant? It's 80, 81, and 82. I can't think of what the second one is, but anyway,
Well, the AS or the AS for the
yes,
physician
yes,
assistant.
yeah. And so what happens is, in order for it to be a credible note, you have to see what each person has done. And this particular note, it was a template straight across. And at the end, it said the assistant assisted with the appropriate services associated with the note. Okay. There was an adverse finding based upon that surgery. The assistant, no surprise, was nowhere to be found. And this patient had some really bad adverse effects. And I was in to review the note. Needless to say, when I first looked at the note, I was like, this is a template. They was like, that's interesting because everyone else says it was a template. How do you know? I said, because it's not specific to the patient and it's not
Mhm.
telling who did what. And it leaves the provider room to put whatever they want as far as the note, right? And let's just keep it 100, Jen. If the assistant is working for the same practice and they're saying that they used an assistant, what happens? The assistant can bill and the physician can bill. So that is unnecessary wasted dollars that could go out the door if they can't prove A, that they did it. And what if they did it by themselves and it was required for them or it was needed for them to have an assistant because they couldn't do all portions of the service? I'm just saying. So this is a big open door, right? And this is where AI can really mess things up if they're listening for what is happening and it didn't actually happen.
This is a huge point. And back, and I think it was 2022 when it was like late 2022 when the audit was available for the OIG did an audit on modifier 62, modifier 80, because they're different things, right? And this is my world. I do surgery. So like, I mean, I talk about it all the time. But 62 is two different specialties, guys, not the same specialty. It's two different specialties
Ooh,
that do typically the approach to a surgery, like a spine surgery, which is we do it often
I
in
was
anterior discectomies, right? Anterior fusions is usually when it happens a lot. And it's that portion, right? The CPT code book says 62 is only allowed on this code, not on grafting codes, not on instrumentation codes. Very clear how to separate the billing and the coding on a spine surgery because the book tells you, and then payers agree. Then there's 80, which is an assistant surgeon, means that they are there throughout the entire case. They're assisting, whether they're an MD, DO, or they're a PA, NP, the modifier changes. You have a minimal assist and you have an assistant
yeah,
you're using because a qualified resident wasn't available if you're in a teaching hospital. So those are the different 80-ish modifiers, right?
yeah.
So those have to be correct, right? But they did this audit and found out, and it wasn't like some of the audits you see were like so much money. It was on the smaller side, but it was still money that they had to pay back, because obviously if you have people not adding the right modifiers at the right time, they're going to, like, you have the same physician, two different physicians on the same day, seeing the same patient, billing the same service. There's a problem, right? They can track it. Like, it's easy to find, because obviously there was a situation going on here. So they audited it, realized they weren't using it correctly, right? Because if you don't both add the 62, one of you doesn't, somebody's getting paid 100%, while the other one's not getting paid probably at all. You're supposed to get an even split of 62.5% as a
Yes.
co-surgeon, right? So if
Yes.
you don't apply a modifier correctly, you're going to have a problem. So that's that scenario. Um, and that's why it's important. It can be tracked, it can be found out, but it's also, like you said, safety for the patient. Documentation is not just to get paid. It's a legal document, like we know. It's supposed to provide the truth of what happened, because if, heaven forbid, something happens to the patient, we have a trail of what truly took place. But it has to be true for it to be, I guess, legal, right? I mean, like, we want a legal document to be accurate. And I think we just get lost sometimes, forgetting that medical records are legal documents. They're just the same as you sign in a contract to buy a house. Like, it's supposed to be real and true. And that's the problem we have in healthcare, is that we can't always trust the validity of what we're looking at. And that's a problem.
Yeah. I think from the sake of a copy paste and the takeaway that's related to copy paste, if you're going to do it with attribution. Attribution is the process of using another physician's note and giving them credit, or giving credit to where its origin is.
Yeah. Yes.
And so when you're looking at the note and you're auditing, and you want to see the validity, because a lot of times what will happen is, and this is what I've seen in inpatient stays, the emergency physician will see the physician first. Then there's the initial visit from the internal hospitalist, right? And so what will happen is they'll take the note from the ED and say, from the ED, this patient, blah, 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 blah. I saw blah, 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 right? The attribution is there, it's creditable, and they've added what is appropriate for the physician who is seeing the patient today, today, or now, right? So you have to be really, really careful. And in my experience, which is quite a long time, give the attribution. If you're going to do the work, show that you did the work, so it
Mhm.
doesn't change the dynamic of whose work is getting credit. Okay? That's the most important thing.
Yes. Cover yourself, because you did the work. You should make sure people know you did it, because, again, like I said, if it comes out later that someone says this happened, well, no, it didn't, you have to have proof, right? Because there's times where patients have come back and said they don't like their bill because, like, this didn't happen, but it's documented, right? So did it really happen? Because the patient's saying it didn't, and the physician's saying it did because it's here in the note. But is there an issue? Whose fault is it? Like, it's hard to prove it unless you it's in there and you can prove it, right? You have to have a trail of something. So that's why it's important too. Now, I'm really excited that at the upcoming Bone and Joint Summit, we have 2 AI sessions and a compliance panel. So Maya and I are both on the compliance panel. And then Sean White, on the first track, is going to be talking about compliance for ChatGPT and AI, which is going to be great. I hear it's an amazing session. If you've heard him give this presentation, it's fabulous from what I hear. I'm excited to hear it for the first time, but I've been hearing some amazing things about it. And then on track 2, we have Dr. Kush Singh, who's going to give us that breakdown of AI and what it is and how to use it in healthcare appropriately. And so I think either way, whatever track you pick for that day, you're going to get good information. But remember, guys, with our conferences, we give you lots of good stuff. So
Oh,
everyone who purchases a ticket gets access to all the recordings of all the sessions. So even if you pick a track and you only get your CEUs for one track, you're still going to get access to the other ones to have the information. So again, we want you to benefit from the entire conference. All of the sessions are so fabulous. Remember, day one is all about reimbursement, administrative things, compliance. Day two is all about coding and documentation. So it's going to be a great dual force 2 days of education. So I hope you can attend the Bone and Joint Summit. Go over to healthcareinspiredllc.com, go to virtual events, find the Bone and Joint Summit, and sign up today, guys. Our swag bags go out on July 1st.
Yay!
I know we have some amazing things going in those swag bags, guys. We'll be announcing on social media some of those new cool things going in the bags this week. So stay tuned. We do have a soft deadline of tomorrow to get your tickets if you want a swag bag, but we're going to go ahead and let it slide. As long as we have your order information by July 1st, we can get it to you by the conference. That's the cutoff, because we can't guarantee you'll get it in the mail by the conference if we don't have your ticket and your information by July 1st. So please sign up, get your ticket as soon as possible so you can benefit from all the cool swag, guys, and enjoy the conference. Next week, guys, we have an amazing, amazing show on the difference between denials and rejections, which I know Maya is 100% an expert in, and I'm pretty good too. So we'll have a good time.
Oh yeah.
And, yes, and July has some great upcoming guests, you guys. We have Sunal Patel coming up on the show in July to talk about behavioral health compliance. And we have Miss Lady Martinez coming back to see us in July. And she's going to be just talking about her efforts with APC chapters and what we can do to support them. And just some great things to just show that you support the coding community and what you can do to help others to support that. So stay tuned for that, guys. We appreciate you always supporting the Practice Perfect podcast. Thank you for joining today, and we will see you next time, guys. Have a great Wednesday and have a great rest of your week.